Dr. Scott Worden, the TOS guy. We're broadcasting a live stream from beautiful downtown Sunnyvale, California. It's gotten cold here and winter is coming. My cats have fur coats that are getting thicker and deeper. We're all preparing for winter. And hopefully everybody in the rest of the country is getting some inclement weather, is doing okay. Also, we want to wish everybody a happy new year. Let's hope that 2024 is a great year for all of our patients. And I'd like to remind everybody, please hit the like button. That helps the algorithm and spreads the word about TOS. Also, please subscribe. We're really close to 1,000 subscribers. And when we get to 1,000, we're going to have a little celebration. It'll help out the cause a lot in terms of raising awareness for TOS. Now, the topic of today's talk, as you've seen, is what we learned about TOS in 2023. As you know, anybody who follows us regularly, we had a series of very disparate presentations and guests, as well as myself speaking on a few different subjects. So what I'd like to do, I'm going to put a presentation, and I've pulled out some excerpts from some of our most popular talks. So our first talk of 2023 was a really great talk for us. We got 4 TOS experts from around the country who are listed here. Dr. Dean Donahue from Massachusetts General Hospital, Dr. Fareed Gargazlu from the Thoracic Robotic Surgery Institute in Orlando, Florida, Dr. R Jenkins in busy New York City, and Dr. Rob Hagan in St. Louis. Let's take a look at some things that Dean Donahue had to say.
Dean, I know you've been waiting a long time. I'm glad you're still with us. So what tools and methods do you prefer to get you on the path to diagnosing patients?
Well, like everybody, it really is history and physical, I think, are the kind of the foundations that the rest of the house is built on. So, trying to get a detailed history and try to do a thorough exam. I do favor a specialized CT angiogram and an MRI protocol that I find very helpful. It doesn't make the diagnosis. I tell my patients all the time, I wish it were that easy. But I do find when you understand somebody's anatomy in as much detail as you can, and you know what their symptoms are, and you know what their exam shows, it just sort of helps me put the puzzle together a little bit. It's never completely together, but I do find it helpful. We also do a lot of injections, trying to inject the anterior and the middle scalene muscles and the pectoralis minor muscles. And I'd say 20 years ago or so, we were doing lidocaine injections, and we switched to Botox by about that time. We've been doing Botox for a long time. And again, there is no test for TOS. I wish it was that easy, but I do think that Botox does a couple things. One, it becomes a useful tool in a lot of patients for their treatment strategy. About 7 out of 10 patients that I send for Botox will get some degree of response, and sometimes it's dramatic and very long acting, and sometimes it's less so. But it can be an important part of the tool. But it, at the very least, it kind of gives me a sense of, is there a component of reversibility? The problem with Botox is I think it's at least when in the public, it's kind of misunderstood. It's thought of as just kind of decompressing the thoracic outlet, which I think that's one of its mechanisms, but it blocks nociceptors, which are the unmyelinated pain fibers within muscle cells. And so it's conceivable we're just giving a really good long-acting pain medicine. It inhibits the release of certain neuropeptides that are important in the pain cascade. And so it has to be taken with a grain of salt, but I do find it very helpful, not just as a tool for diagnosis, but also as a part of a patient's treatment strategy.
We have found now, again, after many, many years of this is bilateral disease. It turns out to be a congenital abnormality of the way the chest formed. This is a different disease than compression of the brachial plexus by other actors in the thoracic outlet region. So it's really important to tease out these patients and have a specific reason for doing a specific operation, instead of the shotgun approach like we heard. So that's not a good idea. So the issue is, here's a patient, they have had a great workup, we have seen lots of good people, and basically now the MR is the only thing that we're looking at, and the only thing that we see on it is compression. of the subclavian ulnar junction by this. You can see the abnormal part of the bone. And again, we have looked at these patients retrospectively, the resected bone, the normal first ribs, and they have a tubercle in that location that's compressing the vein, and it gets worse when they move their arm. So you can see all of that on the MR. The approach we take is basically a robotic, and it has nothing to do with whether you can do it with a robot or not. It's just it's something that we do. And frankly, the robot lets you get to that joint area very easily. And we do this articulated. One of the advantages I can tell you, and my colleagues have said this, you can disrupt the clavicular sternal joint, but with a robot, you get away with just taking out the costosternal joint and not disrupt the other one. So that's an important thing in my own experience, because when I did it the other ways, we had issues with the other joints.
One of the things I've learned is to be a little less aggressive with how much of the costoclavicular ligament I take, because I've had a couple of patients who have developed sternoclavicular instability and pain from that. And I think the EDS patients, these collagen vascular patients of various ligamentous laxity are more prone to that type of problem. And so what I do is I come, very similar to what you do. I come right in forward over the first rib, go straight back. I use some very fine retractors and just basically push the rib down to push the retractor further back. And I get past the middle scaling muscle, detach it completely. I don't go out quite as far back as you do, mainly because if I think I need to go that far back, I'll do it from the back as well. So I do an infraclavicular very similar to what he does. And just, trying to make sure that we impair the normal anatomy as little as possible, resecting the rock from the rock in the hard place that the neurovascular bundle is being squeezed between. And I find that getting back a good 5 to 7 centimeters straight back is really what seems to do the most. And this is from some of the 3D modeling I've done of the CT angiograms. Unfortunately, Scott, I haven't been able to 3D model any of your MRIs. So the CT angiograms are much more effective for putting into it. And when you look at the difference between the arm up and the arm down position and the rotation of the clavicle and backwards, as well as the direct motion, that's 5 to 7 centimeters seems to be the sweet spot for getting past the point where the compression tends to occur.
I think we started to talk about this earlier about just kind of the difference between the scaling triangle, the costoclavicular interval, the subpec minor space or void space. And from my standpoint, what surgery I do and what approach I use really depends on what, if I think they have one or all three of those, and try to stratify care based on that. I think in my practice, at least, the ones I see predominantly are those who have scaling triangle and pec minor. And so 9 times out of 10, I'm a non-rib removal person, but 1 time out of 10, we are. And again, so when we're addressing surgically just the scaling triangle, much like everybody else, we do a subtotal resection, anterior scaling, normalizing plexus. I do a release, a complete release of that middle scaling off of that, as we have, that broad insertion that kind of wraps around to the front and connects like a fulcrum. And then on most every patient, I try to be very thoughtful and specifically look at that dorsoscapular nerve, long thoracic nerve, and that suprascapular nerve as well. Is really, I call it, those nerves to me are part of the scaling triangle syndrome.
I think that was one of our coolest talks, that we had these people with very different experience and training, different specialties, and there are different approaches to this disease. On the one hand, it tells us that there is no consensus, that we've got all these really smart, really experienced people trying to figure out some of the clues to this. But as Dr. Garagoslu mentioned, there are ways to filter out different groups of patients, something I've preached for a long time, right or wrong. I believe that the original designation of thoracic outlet syndrome included a number of different mechanisms of disease. And so lumping it together did not do anybody any favors, and it makes it very hard in any group of patients with similar symptoms to separate them into those that can benefit from different types of treatment. Dr. Donahue clearly demonstrated the multimodality approach utilizing imaging, Botox injections, clinical exam, and history. And still, in private conversations, we know that some patients surprise us with how well they do, or good candidates don't do as well as we thought they would. Dr. Garagoslu talked about the venous compression part of this, which there's evidence that venous congestion, or the limitation of the veins flowing back into the chest, can cause nerve damage over time. R Jenkins, of course, talked about his approach being different. He goes in for clavicular, although he's used other approaches. And he does a lot of work with imaging, such as 3D CT, to try to help figure out the anatomy before he goes in. And then Dr. Hagen talked about, really, he approaches it more as a soft tissue disease and less often has patients who need rib resections. Dr. Hagen's a peripheral nerve surgeon, and peripheral nerve surgeons deal in great detail with small peripheral nerves to larger nerves, but understanding the complexity of each nerve. So it was a really good talk, and I learned a lot just from listening to these different experts. I gave a talk after that on EMG, and I don't believe EMG has a very strong role in the diagnosis of TOS. I went into some detail in my talk, but I learned a lot just by building the talk.
What are the values of EMG and nerve conduction studies in patients with TOS? I'm going to do these as a question or point and an answer. Number one, point number one, EMG is focused on motor nerves and muscles. So motor nerve fibers are large and they're myelinated, and they tend to be centrally located within these peripheral nerves. So damage to those occurs usually after there's damage to lots of sensory fibers, which means late stage TOS. I've said it before, I'll say it again. By the time you get atrophy of the muscles in the hand is most common for TOS. By the time you get there, you've got so much nerve damage, it's much less likely that you will have a complete recovery. So we don't want to wait until we see this. We do not want to wait till we see motor nerve damage, because that means it's been chronic and severe. All that time you've been getting the sensory nerves at the periphery crunched, and you're getting symptoms, various types of vascular deregulation, color changes in the hand, pain, tingling, burning, numbness. You've been getting that all along before the motor nerve gets damaged. So one of the things that's changed from 25 years ago to now is we don't see as many patients in this later stage. We're making the diagnosis more quickly.
All right. And then we had a patient who had been on our live stream some time ago, an elite athletic swimmer, a college swimmer by the name of Jake Markham, one of our more popular videos, partly due to Jake's story, his family support. His father is a cardiologist, and Jake had a very sudden presentation of a blood clot in his veins. They didn't know what was going on at first, but they got a rapid diagnosis, and they had a good surgeon help Jake. But of course, being an elite athlete, even minor things can upset your skill set. And so Jake, as a young man, had to deal with a lot of ups and downs.
Swimming up until that point in my life had defined me. I had it taken away, and I had to figure out who I was as a person and how I was going to function with the idea of not being a swimmer. Fortunately, I was able to continue swimming and have been able to do it at an elite level. But I had to do soul searching during that period of time and figure out who I was, who I wanted to be, because I didn't want to be just a swimmer, and I didn't want to be somebody who just has TOS. I wanted to be my own Jake Markham, who makes my life and defines it my way. And that's something that helped me go through this whole process, because I knew that TOS doesn't define me. Like I'm gonna conquer this. I'm gonna get through this. Because I don't want it to hold me back from what I want to do in life.
And we've heard in the interval that Jake has been admitted to at least two different dental schools. I think he's got a bright future, and we're glad that he's gotten through the worst of this. Our next talk was with Yingu Lum. Dr. Yingu Lum is, I believe, an assistant professor at Johns Hopkins and has his own TOS clinic. Very smart guy, well-spoken.
Can cervical ribs contribute to venous compression?
Great question. I've come across one case of that happening. It was a colleague that I know that lives and works in Brazil now. And they sent me a picture in their films, and it was truly a patient with a cervical rib that had venous TOS. Now, in general, I think cervical ribs protect you somewhat from venous TOS, just because when you have the cervical rib, usually your first rib is going to be a little bit lower. And usually the cervical rib is not a complete rib that goes all the way to the front. So in my mind, I think of the first rib being lower on the sternum. And if you think of the floor being lower in the house floor analogy, I think cervical ribs actually protect you from venous TOS. Not to wish anyone to have a cervical rib. Most patients with cervical ribs will live their lives without any symptoms. But I don't think cervical ribs in general predispose you to venous compression.
And Dr. Lum, as I said, is at Hopkins, a place where I did some training. He's young, energetic, smart, really easy to talk about TOS with, and definitely on our list of people that you might see if you're a TOS patient. So then we had Dr. R Jenkins talking on a topic that he's touched on before in various ways. Why is TOS so hard to diagnose?
Now, I've often said that seeing is believing, but believing is necessary for seeing. So you will never make a diagnosis that you don't believe in. You'll never make a diagnosis you're not looking for. You will never make a diagnosis that you were never taught how to do it or how to look at it. So if you're not aware and actually not looking for it, you won't see it. So many people only diagnose what they see regularly, or they want to treat, and they just say, you know what, that's not in my wheelhouse. Why don't you go see somebody else? That's just wasting your time and it. We talked a little bit about the TOS issues. And unfortunately, occasionally, patients get pigeonholed with fibromyalgia. There's a pain somewhere I don't understand. And the problem is, many patients who get a diagnosis of fibromyalgia, it's almost like a stigma. It's almost it's a stigma that says this person can't be made better. We can only give them drugs. There's nothing that can be treated surgically, medically, injection-wise. It's just fibromyalgia. Nothing more to do here, just make them comfortable and just help them deal with it. And a lot of times, I actually have seen it written up that published 10% of patients with fibromyalgia actually have a Chiari malformation at their brain cell interface, let alone TOS, Bertolini syndrome, May-Thurner syndrome, and so many other syndromes that somebody just didn't think of. And so when it wasn't one of the top 5 diagnoses they treat, they said, must be fibromyalgia. So what should you do as an informed patient? Keep trying. Keep trying. If that doesn't work, keep trying. Don't give up until you find someone who will both take your concerns seriously and help develop a plan how to manage it. They've got to get it. They got to have a plan for it. And that plan has to have a start and an end, that they move you on to a next stage once they've exhausted what they can. So they've got to understand the workup. You as a patient need to understand that the workup may be extensive and require uncomfortable imaging and testing. I will say that Scott's MRI, nobody ever comes to me and says, Doc, that was the best MRI I've ever had. It's uncomfortable, it's unpleasant, it's meant to be because we need to image the patient in the most uncomfortable position because that gives us the most information on where the depression points are, where the irritation points are, where the pain points are. And without that, it's useless. So sorry, but it's sorry, not sorry. So ultimately, you need to be prepared to work hard to avoid surgery and then to recover hard after surgery if necessary. Because if you don't re-stabilize and re-support those 17 muscles on the scapula, you're going to be coming back with more problems down the road.
And for those of you who are not aware, Dr. Jenkins is a neurosurgeon in New York City with academic connections as well as private practice. Very, very interesting guy. Next, I did a talk on the forgotten space of TOS. Now, I love anatomy. Most radiologists learn a ton about anatomy. Sometimes it's unclear whether it's even important, the details that we learn about it. But in this case, for obvious reasons, I think it is important. This is the pre-scaling space.
Now we're going to take a look again from the side, the lateral view. And we're going to see that there's this space bounded by the purple box here. And this contains the subclavian vein. I briefly mentioned before that the subclavian vein does not go through the scalene triangle. But here it is in front of the anterior scalene muscle, or pre-scalene, the pre-scalene space. And this is a slightly complicated space that has a lot of importance to patients with various types of TOS. So we're going to discuss it today. This is the forgotten space. Here we can see the collarbone on the first rib as the bony landmarks. The collarbone is the roof of this space. The first rib is the floor of the space. And you'll see the subclavian vein goes through the pre-scalene space. The anterior scalene muscle is at the back of the space. We're going to look at it in more detail. First, let's go to the frontal view. And again, we're going to put this little purple box around the space that the subclavian vein goes through. It's in front of the anterior scalene muscle, and it's between the collarbone and the rib. This is the pre-scalene space. Again, the labels show the clavicle as the roof, the first rib as the floor, and the subclavian vein going through that space. The back margin of the pre-scalene space is obviously the anterior scalene muscle. All right, here's some bony anatomy. We see the clavicle, the collarbone, as it comes up and joins the sternum or the breastbone. So we get a sternoclavicular joint. And then an important structure is this costoclavicular ligament. Costo meaning rib, clavicular meaning clavicle. And so we get this ligament of various sizes and shapes. It starts on the first rib and inserts on the very medial or forward portion of the collarbone. Here's just another picture of it reversed. You'll see the text looks reversed here, but this is merely to show another example of the costoclavicular ligament starting on the first rib and going up to the medial aspect of the collarbone. Now, there's another important structure in here called the subclavius muscle. This rides just underneath the collarbone. So in fact, the roof of this space, the roof of the pre-scalene space, is partly bone, collarbone, and it's partly soft tissue, the subclavius muscle. If you look just under the subclavius muscle, just to the left of the purple arrow, see a small piece of the first rib. So what does this look like on MRI? This is a similar sagittal image. You can see quite clearly the subclavian vein. And now this is what happens when the patient raises their arm. This is the subclavian vein. And you can see, in this case, I'm not sure whether it's the tendon or the ligament, but clearly it's compressing that. So let's go back and take a look. This is with the arms down. By the patient's side, we see the subclavian vein nice and round. Now this is with the patient's arms up. And we see the subclavian vein is severely flattened, and that prevents blood from flowing easily from the arm back into the chest.
All right, then we're going to go from really dry anatomy to a very interesting family where the dad is a chiropractor and his daughter had symptoms for years. She'd been a very good athlete, but she had sudden onset of pain when I believe she was 8 years old, Ariana. And they came to us because the dad would never give up searching for an answer. And he found TOS and he pursued it, and we got to work with them.
What did you go through emotionally during this period?
I think that it was probably the hardest thing that I've ever been through, especially from the very beginning when I wasn't aware of how to be vocal about my feelings and my symptoms, and I didn't really understand what they meant. I was so young. So I think that speaking with so many doctors that initially thought that it was some kind of phantom pain or in my head, and then referring me to see psychologists and different doctors, that was really defeating. It was horrible because I didn't know how to show anyone that something was wrong with me when all these tests that I'd been doing for years and years were coming up like everything was okay.
How did you feel in the different doctor's offices? Did you bring up TOS?
Oh, I did. And you know, they would put her through a couple tests, kind of say, well, it's not, I don't think it's Thoracic Outlet Syndrome. And in the back of my head, the difficult part was looking at people that I refer patients to and work with who were telling me no. And I'm like, in the back of my head, I'm like, yeah, it is. That was the hardest part. And then, you know, my family was like that, you know, how do you know that this is what it is? If everybody's telling you no, why are you so stuck on it being Thoracic Outlet Syndrome?
Because you're Ariana's dad and you're stubborn like her.
Yeah.
Now I feel relief, definitely. I haven't slept as well as I have now since before I got Thoracic Outlet Syndrome. I just came back. I was able to fly in a plane and I didn't have to sit in an aisle seat or like get up every like 10 minutes to like move my arm and move around. Sitting in class is getting easier. Like my studies are getting better. I just feel like overall like much happier as a person because I think there was always a part of me that was like somewhat bitter just because I didn't know why I was in pain for so long and like why I couldn't find help and why I couldn't really find someone who would put the time in to help me. But it has definitely changed my life. And I know the surgery doesn't work best for everybody, but it definitely worked so much better than I ever could have imagined.
And shout out to your surgeon in New Jersey.
Yes, Dr. Ignacios. Thank you so much.
Yeah.
And thank you, Dr. Werden, for showing me the diagnostic test that led me there.
So as I'm sure many of you can empathize with, having doctors who can't see the disease or won't see the disease on top of all the symptoms and the challenges and life changes can be emotionally very frustrating. Our last talk of last year was Dr. Jim Avery, incredibly experienced TOS surgeon, also does heart transplants and a lot of other really critical surgeries here in San Francisco. He talked about this issue as well because he and I have worked together. He longer than I have on TOS, but we've worked together for a couple of decades, and we've dealt with this kind of bias and trying to help patients get past it.
And I think, unfortunately, that was the case for most doctors. It was appalling to me that people had the attitude that if I can't find it, it being a diagnosis that this patient has who's got a normal neurologic exam but is complaining of nerve symptoms in the arms with their hands and arms in certain positions. The attitude was very common that if I can't diagnose it, it doesn't exist. And I'm sure patients out there, some of whom have heard, probably most of whom have heard from a variety of doctors before they get to a person who does believe this thing is real. It's not imaginary and it's not made up. Before you get to that sort of an individual, you hear that you don't have anything wrong with you, and it must be very disappointing, to say the least, to the patient to hear that the thing they're suffering with isn't an entity. But that was the prevailing attitude at the time. There were people, even back then, that believed in it, but unfortunately, it was sort of unpredictable in the sense of who would have function immediately post-op. So I got a new approach based on an observation after doing this for 10 years, that from an infraclavicular approach below the clavicle, one could get far enough back to do what I considered to be an effective removal of the rib, which was to remove the bottom of this bone-on-bone vise that some people have as a functional problem. When I've reached the point of thinking I've done enough surgery, and what I'm doing is I'm looking through an access of about this much space. And at that point, I put my finger on the stump of the rib. So I'm under the patient's clavicle, and I'm moving the right arm up and back as I'm demonstrating right now. And I do that because that's the most provocative position one can be in, moving the clavicle as far posteriorly as it can go anatomically. And if in that position, there is no contact between the clavicle and the first rib, I stop. So I'm very cautious throughout the whole operation, but especially so when I'm getting very close to the back where I know the nerves are going to be, but I don't want to see them. I want to stay away from them. So in this approach, I'm going under everything. I'm going under the subclavian vein, which sits right under the clavicle, under the subclavian artery, which loops up a good bit higher than we normally see from textbooks. And then finally, the brachial plexus nerve roots. Yes, well, as a matter of fact, it's one of those things that you don't really know anything about before you get into the subject. And that is that it's usual, and this was from my experience of 10 years of doing this, to see C5 and C6 going through the body of the anterior scalene. It's not just near there. Frank Denner, in his drawings, bless his heart, always does simplify things for good reason. It's easier to learn it initially, and then you get into the actual anatomy, and the details are a little more complicated. And we're all, as you know, we all have the same stuff, but the details of how it's arranged is quite a bit different from one person to the next.
The anatomy books always show it as the nerves going between the two muscles, but that's not reality.
And that's not reality. The nerves are going through the muscle, or it would be extremely unusual for that not to be true. C5, very typical. C5 and 6 often, and 7 often was going through the middle scalene. So the idea is you can't just go walking through the scalene muscle without first peeling it back to see if there's a nerve underneath. And if so, you have to kind of extract the muscle from around the nerve. And that's the kind of manipulation that makes the nerve very unhappy.
What do you think? What are the changes in the diagnostic approach you've taken over your career? How have things changed, and how confident do you feel in making the diagnosis?
Well, I've come to rely on your imaging approach, Scott, so much that I am very reluctant to go forward with an operation without. And I think, unfortunately,
Over your career, how have things changed, and how confident do you feel in making the diagnosis?
well, I've come to rely on your imaging approach, Scott, so much that I am very reluctant to go forward with an operation without the confidence that I get from seeing the results of your scans. Namely, to see that when the patients are in the scanner with their arms elevated, hyperabduction, there is bone-on-bone proximity, and in some cases, severe proximity, closeness, that the two bones are acting like a vice.
All right, sorry for the technical difficulties in the audio there. I always throw in this slide for some of my live presentations because TOS is a disease that really requires a team. There are different experts here. I won't say which one of these is the surgeon and which one of these is the radiologist, but it doesn't matter because all as a team, if we work together, that's the best way to help patients. So thank you for watching this show and tell. And now we're happy to take some questions that might come up. Carolina, I'm a doctor. I'm having a really hard time. My TOS is affecting my vision due to the compression. Has this happened to any of you? Can we go back to the prior, please? Thank you. She's having pain throughout her shifts. So, Carolina, I don't know where you are in the diagnosis. I hope that you have a TOS specialist who's working with you. If not, you can reach out to us through our website. We have a big contact us button, and we're glad to help you find specialists in your area or as close to you as possible. There are also, excuse me, there are also TOS specialists in parts of the country that do teleconsults, so you don't have to necessarily live by somebody. So please contact us, tosmri.com. Cheryl Mack, I was diagnosed with bilateral neurogenic TOS in 2017 after having symptoms for several months. I was fortunate to have a few delays in getting a diagnosis, which I attribute to having an extraordinary PCP, primary care provider. I flew to UC Davis. She had an experience at UC Davis. They were depriving surgery patients of post-op pain meds, and I have gene defects and need more than most for analgesic purposes. I've often wondered if the lack of pain medications and post-op relief, if that attributed to the failure of my surgery. It wasn't until I returned to Portland and saw my pain specialist at day 10 post-op that my post-op pain was properly treated. Well, first of all, I'm not a pain management specialist. Let's see, this is a question for TOS Education. Wondering if there are any neurogenic TOS redo specialists. We have west of the Mississippi that you can recommend. I've delayed pursuing this because I had a bad all right, don't know if that's the last part of the question. Surgical experience. So obviously we're not privy to your medical record and we don't discuss individual health care or recommendations here. First of all, we're sorry that you've had a bad experience and sorry for anybody who's suffering through TOS and not getting treatment promptly. Overall, I consult with patients and I'm glad to talk with you if you reach out again through our website, tosmri.com. But let me just say this, in general, surgery is done differently in different places, as we saw through our panel of 4 different surgeons. And sometimes the right surgery for some patients may not be the right surgery for other patients. So it depends on what tests you've had pre-op. If you had any imaging that showed specifically what was going on, it would depend on the surgery that was done because there are many variants of surgery. And then I'm not in a position to comment on post-operative pain meds. It's just not my specialty. But if you reach out to us, we'd be glad to talk to you and help you or help get you to a person who does redo operations or can talk to you about this. Thank you for the question. While Latina, if you have bilateral venous thoracic outlet syndrome, are both sides usually done or just one side for the rib resection? So that's a good question. I definitely see bilateral venous TOS as uncommon. If you've had these clots form on 2 sides, hopefully your doctors have checked out for hypercoagulable states where the blood clots too easily. It is fairly frequent that we see patients with blood clots and venous TOS, but one side only. So then the question comes up, there are some controversies about treatment of venous TOS. Do you dissolve the blood clot? Do you put a stent or a metal cage in place? Do you resect the first rib or some of the adjacent structures? Do you do post-operative imaging like venograms to see what's happened? angioplasty, where you put a balloon in place and inflate it if the vein has a stenosis or a scar that narrows the vein. So there are many variables in this. In general, I think one of the more common approaches is reasonably urgent dissolving of the blood clot, even though the blood clots in venous TOS are less likely to cause pulmonary embolism to the lung and pretty unlikely to cause a stroke, very unlikely. But still, they'll try to dissolve the clot quickly. Most docs will get an ultrasound and then usually a venogram because they want to see detail about the inside of the vein. Does the vein have a scar that narrows it? If that's the case, excuse me, they may go, excuse me, they may go and do a venoplasty, again, the procedure with a balloon. You put a little catheter in, run it up to that area, and then inflate the balloon until the vein opens up to normal caliber. And then sometimes they'll put a metal cage, a stent in place to keep the vein open. But depending on what imaging has been done, if the vein is compressed by the collarbone and the rib, the stent will be of little value. It'll just get crushed very quickly and it'll be narrow again. So I definitely recommend in those settings either a CT venogram with arms up or an MR venogram with arms up so that you can see what is causing this compression on the vein, if any. And then usually a few months post-op, while the patient is on a blood thinner, they'll come back for a venogram. If things remain open, they may be taken off the blood thinner and then maybe followed up with another venogram a few months down the road. So that's the general approach. In terms of bilateral, if you have a blood clot in the arm and it's coming from that vein, then both sides need to be done. I hope that helps with your question. Okay. So as you see on the bottom here, we're going to have TOS care models. 2 different patients share their experiences. And this will be 2 weeks from today on February 23rd, 2024. Please click the like button now if you haven't done it already, and subscribe if you can, and hit the little bell by the subscribe button so that you'll get notice every time we put up a new live stream. And then hopefully visit us on our social media, including Instagram, YouTube, Facebook, and is that it? Twitter. We even have one on Twitter, although it's not very active right now. So thank you very much for attending. We hope this has been a nice informative review of 2023 in TOS, and we'll see you in 2 weeks.